and the global availability, often by using advertising or facilitating distribution and certainly bypassing regulation, and what that might mean in terms of how we might have to make responses both in policy and implementing them. And then I'm going to also touch a little bit on the use of large data sets, some of which are derived from internet surveillance, but other from routine collective data, something that we've been working with extensively in Australia. So when I'm talking about toxic vigilance and routine data, so-called look to coordinate approach by looking at existing
recording
data.
In progress.
Examples would include linking poisoning centre call data to the data from hospital clinical toxicology treatment centre, database, social media data, emergency presentations, ambulance presentations, and such. And so this has been the approach that we've really exploited over the last 10 or 15 years in Australia. And as a part of this, we're currently advocating that many poisons should identify the disease, because this is probably the way to get most kind of rapid case pickup. And the reason we need to do this is that the burden of fatal and intentional self-harm is huge. This is a picture of the world redrawn to account for the actual frequency of intentional self-harm. And you can see, obviously, that much of Asia is overrepresented, and this by and large has been driven by deaths from intentional poisoning to pesticides, something that Sri Lanka addressed significantly over the last 10 or 15 years. But it always has been dynamic. And pre-internet, this is going back looking at deaths in women in the United Kingdom, and I'm going to give you two examples here. The first is, this line here is death from coal gas. So it was frequent. Once it realised that this was causing a lot of deaths, predominantly by people asphyxiating themselves, they removed coal gas from the gas supply, and there was a dramatic reduction in deaths. At the same time, in the next line here, you can see another peak. These were drug deaths, and these were predominantly barbiturates. Again, once this was realised that this was a driver, prescription guidelines, access to barbiturates were changed, and deaths dropped off. So in these examples, we have something we can identify, but we actually have things that we can control by regulation. And that's not where we are in 2021 in many instances. The other interesting thing about this graph is that despite these large peaks here, the background level of other causes of self-harm doesn't change. And so by and large, self-harm is often opportunistic, and people do not tend to switch methods as much as people often suppose. So means reduction is very, very important. So the first thing I want to talk about is a little bit how we think that the epidemiology is starting to alter. This is my colleague, Dr. Rose Cairns, and she has conducted extensive research and leads this in Australia. And so this is the graphs looking at the numbers of self-poisoning in children and adolescents being notified to the poison centres, and we get about 200,000 calls documented a year. And what you can see here is that there's been an increase from about 2011 in both children and adolescents, and notably that increase is very dramatic in young women and in females, to the order of about 3 times as much. So this really drove our interest about trying to understand what's causing this and what potential interventions we might be able to do. At the same time, or shortly after we published those papers, a series of other papers have come out from various other countries in the world, all showing exactly the same sort of increase, predominantly young women, a fairly sharp increase around 2011. So this was a global phenomenon. we suspected. So the way we decided to look at it, Rose set up an examination of both birth cohorts. And so what a birth cohort is, I'll give you an example in a second, but you follow all the children born at a certain year, and you follow each year as their own cohort. And the reason that we do this is it allows us, by looking at multiple cohorts in sequential years, to see is there a clear sort of temporal takeoff point that we might be able to relate to some social change in social context or some other events or something in the environment that may have implications for how we may want to address this increase of self-harm and suicide. And so here's an example of a birth cohort here. So if this is a 14-year-old girl who presents in 2014, and she is from the birth cohort of 2000. And so that's an example of the birth cohort. What Rose then subsequently did is she set up birth cohorts looking from 1995 onwards. So in 2004 in this graph, each birth cohort represented by a different colour, and this is the first point that she took. So here are the 19-year-old girls, so they were born in 1995, and here is the children at 5, presenting with toys were born in 1999. And so we then continued to plot all of those age groups to look at what happened to their trajectory and when they would peak. And so you can see that all of these birth cohorts here, up until 2008, 2009, 2010, are largely following a very similar pattern. And that pattern suggests that the self-poisoning peak is around about 16 years of age. This is both in males and females. But then, 2011, where we started to see that other data, from 2012, we started getting a shift in the curve to the left. So these younger cohorts were starting to self-poison at an earlier age. And so by 2015, it appeared that we were getting a peak at around about the age of 15. So there's been a shift that we've noted in Australia, but this is now shown in other parts of the world, to a younger age. So it's not just an increase in the rate or the amount of presentations, particularly in young women, but these are occurring at an earlier age. Okay. We call this phenomenon Y2K. Effectively, why is the year 2000 birth cohort got this accelerated and earlier onset of self-harm? And there were a number of theories that have been generated around this, and in particular, based on some other qualitative work, there's a lot to suggest that the internet has a very important role, social media, and this includes things such as body shaming, direct internet abuse, in some subgroups, actual groups promoting self-harm amongst peers. So previously, things that might have been confined to an individual schoolyard or a more geographic environment now have much greater ability to spread. And this has really important ramifications in terms of what we might want to teach children about how to address and how to handle such stresses on the internet, if indeed this is the underlying cause. But this is probably the most plausible explanation, at least based on the qualitative research in young people and self-harm. So that's change in the demographic epidemiology. I now want to show you something around about availability. So this is a salami on the left, and this is sodium nitrate, which is a compound used to preserve meat. It is legal, it's used in sausages, curing other meats. It's a legal compound. And as such, pretty easily accessible and really had no barriers to exposure. Then what happened in late 2016, early 2017, a new edition of this book, the Peaceful Pill E-Handbook, which is a book that gives various methods for people to euthanize themselves. And it promoted sodium nitrate as a peaceful way of dying. Now, in fact, what sodium nitrate does, it causes extremely rapid onset of severe methemoglobinemia, which, as you know, methemoglobin doesn't carry oxygen. So effectively what happens to patients is they become severely and acutely hypoxic, They have significant amount of pain and generally will die often within a few minutes, losing consciousness, having a cardiac arrest for which we cannot resuscitate people. I'll come back to some of this data later on, but we started to look at the data here and see how, this is just in my state of New South Wales. So in the blue is our national coronial data. So the coroner enters this data once they declare the cause of death. Because of the backlog that can take up to 1 to 2 years. So here we can see an increase of coronial data in New South Wales. The apparent peak in 2020 is probably not real because of the delay of data entry for these years. But to put this in perspective, this is about twice the number of deaths that we would have for paracetamol or paraquat nationally. At the same time, we could look at our hospital data, and our hospital data, we can see much fewer cases presented to hospital. The reality is that this just reflects how highly lethal this poison is, and virtually everyone is dying outside of hospital. Even when the ambulance arrives, it's very difficult to resuscitate patients. Well, it's impossible to resuscitate if they had a cardiac arrest. If they're severely unwell, you may potentially be able to do it by giving them an antidote in the field. So this book was intended for the elderly, but we can actually look at the bimodal pattern, and by far we've got these young people, and those young people were not terminally ill. The vast majority of them had prior psychiatric illnesses or psychiatric diagnosis or history of prior self-harm, whereas the second in the 80s was much more likely to be related to chronic disease. And so this is probably an unintended consequence of this book, that this data is out, this information is out there on the internet and unfiltered. And it's very, very difficult to deal with. So some of the things that we did to approach this is we firstly wanted to make sure that we could capture this data a lot more clearly. So we made certain that we were actually introducing new codes so that this was not hard to retrieve, so we could take data more in real time. We also offered up new treatment protocols, in particular implementing treatment by the ambulance, and the increased reporting from our tertiary toxicology admission centres, as well as our routine surveillance of emergency presentations. But dealing with it is actually quite difficult. If you've got a product that has a legitimate use, that is cheap and that's easily available, then this is not as simple as turning off the gas or getting rid of barbiturates. So we had to implement continuous online toxicovigilance of internet sites marketed in Australia. Those internet sites, if they're a bit ambiguous about what the purpose is, there is an e-safety commissioner, or we can ask those sites to take that information down. If it's clear that they're promoting suicide, we inform the police and they can be charged, but clearly this can only work with internet sites based in Australia. Some of you may be aware that at one stage Amazon was selling effectively suicide kits, but not really aware of what they were doing. In relation to further limiting supply, we've changed some of the poisons regulations in all of our states that at least reduces how it can be sold across the counter, but this does not really interfere with the sort of global traffic of this stuff, which you can obviously post very easily. So if customers pick this up, it does fall under other regulatory forms, their industrial chemicals scheme, which does deal with importation. But so whilst we can notify them of the problem, this still comes down to an issue of enforcement, and that's actually very, very difficult, given that someone only needs a very small amount to literally cover an envelope. Our current major approach to this, which is taking a longer time, is to reschedule the nitrate from Schedule 7 to Schedule 10, which just makes it a poison and means that it can't be marketed at all. And the way we try to approach this is to say, well, there's sodium nitrates, which can still be used for preserving sausages and other meat. It does cause methemoglobinemia, but the onset is actually quite slow because the nitrate has to be converted to nitrite in the intestine. So this doesn't get us out of the woods completely, but gives us an opportunity to treat patients. So this is a really good example of how difficult it is where you've got things being marketed directly in the internet, often not even using this name of sodium nitrate, it'll be called the pink salt or other such things. We have a similar problem with recreational drugs. The recreational nitrous oxide is common in Australia, it's common all around the world. In these surveys of people who are recreational drug users, between a quarter and a third of people will use nitrous oxide. And the problem with this is that nitrous oxide will inactivate vitamin B12, and in doing so, will cause people to become B12 deficient, and then we are having patients presenting with severe subacute combined degeneration of the cord. They're often using these nitrous oxide 2 to 3 hours a day, and they can very rapidly deplete their B12 that start to demyelinate. They can also have central damage, so that you have psychological injury, certainly some episodes of psychosis. So we've got something that's legitimate use is actually for whipping cream. Obviously we can use it in anaesthetics, and that's all regulated in Australia, but for the legitimate whipping cream use, it's meant to be freely sold, but you should not be able to buy more than 6 of these small canisters. And so we knew it was a problem because we were starting to see some patients in our own hospitals, but it's very interesting to see how a low frequency poisoning can jump up quite quickly. So these are just calls to the New South Wales Poison Centre. So not every hospital is going to call the poison centre about any poison, that's voluntary. But I'm going to make the point here, you can see the absolute numbers are actually quite low, 1, 2, and so forth for many, many years. But then in 2015, perhaps a little bit, quite a big jump in 2016. An absolute number of only 10 of calls, but this was something that we subsequently found was often being missed in emergency departments, or not really being reported, people being mentioned under neurology. But one of the things we've been doing is social media analysis, and this analysis here is just looking at Google search trends. We've also got software that will allow us to look at other social media such as Instagram, Twitter, and to look for these trends. And so this looks over here, this is the number of calls, but the trend over time, and it correlates very well with these increases. And the reason, what was actually happening in Australia is people were actively marketing this. There are companies in most major cities in Australia where you can ring up and say, at 2 o'clock in the morning, and say, I want to make a lot of cake with a lot of cream, and they will bring you around 200 canisters of nitrous oxide. All highly illegal, but really hard to regulate. And so we have been moving again to try and alter the regulation of nitrous oxide, increase public awareness, have direct messaging to user groups and other harm minimisation methods. But again, an example of what the internet has brought us now, these sort of unregulated, fairly dynamic changes. The other approaches that we take, more in general to self-harm, go back to our traditional topics of predominantly looking at poisons from chemicals and pharmaceuticals, which is still a major burden of health. And we've done a lot of data leakage studies, but this is a fall one, again, led by Rose Cairns. The acronym is PAVLOVA, but effectively, this is a data leakage of about 8% of the New South Wales population, where we can identify the accredited patients to a range of services, the poison centre, ambulance, emergency hospital, coronal data. We can link that individual patient across all of those data sets. We can look at their prescribing patterns and other information. And we can look at that both for poisoning, but also adverse drug reactions, a range of other events that we're of interest in. And we can do this, and it enables us to look at other potential precipitants and things that we may be able to audit both by changing access to means or looking at targeting intervention. So for example, this information we can take down to geographic location, which we've got a clustered here for rates, but this has told us in actual fact that our rates are actually higher for poisoning in some of our fairly remote rural areas. So these are all adjusted for population. So we have rural areas where overrepresented rates, and there's lots of reasons and stresses for that. And again, this is really a familiar story also in Sri Lanka. So this is a sort of one example of data linkage. And so we're using that to look in particular at repeat self-poisoning. In Australia, the rate of deliberate repeat self-poisoning at 1 year is around about 20 to 30%. In Sri Lanka, the work done by a number of people, including Janaka Pushkamara, shows that it's much lower, as it is in other parts of Asia, at around about 5%. To look at death and to look at the methods and to see what we may be missing and what other interventions we may be able to plan. Other data linkage we've looked at, which we've exploited quite a lot, is looking at restriction of pharmaceuticals. And this is just one example, again, led by Roe, the counter COVID. It was being widely and widely pushback has been removed completely and all only. This is the period where it was removed, and there are, you can see a fairly dramatic drop in statistics thereafter. This graph here, we've split out the low dose, which is in green here, and the high dose, which is 30 milligrams, which was always prescription. And you can see after that ban, there was a significant drop in the target one, which was the low dose, so that had reduced dramatically. It didn't seem to be replaced by people switching and getting prescriptions for 30 milligrams. In fact, largely the companies just removed these low dose preparations. So this is an example where we've been able to use big data sets to convince the government to make policy change, monitor the effects of those changes, and then feed back to the government. And at one point, the government didn't really want to make this prescription only at all. They thought perhaps the pharmacist would just dispense it. I haven't shown that data, but we showed that that had no effect at all. It really needed to be scheduled up, and we put it in for a range of other drugs, pregabalin, some benzodiazepines, all of which showing similar benefit, but importantly able to feed back the policymakers to inform them pretty quickly whether their policies are being effective, and we can continue to monitor to see if other things are emerging to replace those drugs. But finally, the internet's really changed the poisoning landscape, primarily because it's so nimble and it's largely unregulated, and it really does mean that the marketplace is global, and as such you can move things around, and it's really probably beyond most border controls to really address this, especially if they don't even recognise it potentially as a poison, as was the case with sodium nitrite. So increasingly we feel that our policy responses require close to real-time monitoring to pick up signals, but also to inform on the effect of any interventions. And our toxicology in Australia has been very much enhanced by the use of the multiple data sets often with significant data linkage. Thank you very much for your attention.
Thank you very much.